Thanks very much, Sean, for that kind introduction, and apologies to everyone for the slight delay in the start due to projecting problems. So I'm going to be talking about the PACE trial, and particularly today about the acute toxicity. But before we go onto the study in detail, I'll just have a quick brief discussion about where we got to where we are with hyperfractionation and place the PACE trial in some context. So many of you will be familiar with the concept of moderate hyperfractionation, and there are numerous studies in this domain. But particularly in the last few years, we've had the completion of 4 very large randomized trials from across the world. The CHIP study in the UK, the PROPHET study in Canada, the RTOG study from the US, and the HYPRO study from the Netherlands. And they all did something pretty similar, comparing the standard fractionation of 1.8 to 2 gray to between 3 and 3.4 gray per fraction. And I'm not going to go through all the results, but I'm just going to highlight one of them being the CHIP study, which is the largest, 3,262 patients, and randomized between the standard of care, which was 74 gray, and 2 experimental arms, 60 gray and 57 gray. And importantly, it showed that 60 gray was non-inferior to 74 gray. It also actually showed that 57 gray was not non-inferior, so it could not be recommended. But this study, and together with the PROPHET study and the RTOG study, has really, in the UK, changed the standard of care in this cohort of patients from conventional fractionation to moderate hyperfractionation. Also, I just want to quickly show you what because we're going to be discussing the acute toxicity results from PACE, what the acute toxicity looked like in CHIP. So these are the graphs for the grade 1, the grade 2, and the grade 3, the top lines being the grade 1. The blue line is the conventional fractionation, and as you can see that the peak for bowel symptoms for both the moderate hyperfractionation schedules was slightly higher, came on earlier, but ended up in the same place as the conventionally fractionated treatment. And then on the right for bladder symptoms, again, the toxicity came on a little bit earlier, peak was about the same, and again, ended up in the same place. So this wasn't particularly surprising that moderate hyperfractionation had slightly higher toxicity early on. The pleasing thing was that there was no change at 18 weeks, or no difference. And also not surprising really that the toxicity for the shorter schedule came on a bit earlier. So the PACE trial. So the PACE trial is an international randomized study of 2 things: prostatectomy versus stereotactic body radiotherapy, and also conventional radiotherapy versus stereotactic radiotherapy for intermediate and low risk organ-confined prostate cancer. So the aim is in the primary management of early stage organ-confined disease to determine whether hyperfractionated stereotactic body radiotherapy offers benefits over prostatectomy and conventional radiotherapy. Initially, the study was completely a cyberknife study, and it was entirely funded by Accuray. During the course of the study, the sponsorships changed from Accuray to the Royal Marsden. However, the funding remained Accuray. So Accuray agreed to continue to fund the study. But when the Royal Marsden took over sponsorship, we opened the study up to LINAC-based radiotherapy, which did 2 things. One, it meant that this was not only a CyberKnife specific study, it also meant that we could expand to a far larger number of centers, which you'll see significantly aided the recruitment. But Accuray retained the sole sponsorship of PACE-B, this arm of the study. So the patients have to have early stage prostate cancer, T1C to T2C, Gleason 3+4, so Gleason 4+3s are excluded, and PSA had to be less than or equal to 20. And then if surgery was their standard of care, if patients were considering surgery as their treatment option, they would randomize between prostatectomy, robotic assisted or laparoscopic, and SBRT 36.25 gray. And that was PACE A, still running. And then PACE B, exactly the same cohort of patients, but if they were electing for conventionally fractionated radiotherapy as their treatment of choice, they had the option to randomize between conventional fractionation and SBRT. When we started the study, the conventional fractionation was 78 gray in 39 fractions, but we wrote into the protocol from the start that if the results of the CHIP study and other studies which I mentioned earlier showed that 20 fractions was non-inferior to 78 gray, then centers would have the option to switch from their 78 gray to a 4-week schedule. We have a third study which has literally just started, which is PACE-C. So in PACE-B, none of the patients got hormonal therapy. So they randomized to radiotherapy alone or radiotherapy or SBRT alone. No androgen deprivation was allowed. But in the slightly higher risk cohort of patients, so Gleason 3+4 is in more than 50% of their cores, Gleason 4+3 or Gleason 4+4, up to T3A, but node negative and not T3B. And if their PSAs were between 15 and 30, if they have one of these two features, they would be eligible for the study. All the patients get 6 months of ADT plus, and then they're randomized to either IG-IMRT or SBRT. And this study opened essentially last week, and the first patient randomized. So we have one center open, but all the centers that open PACE-B will be able to open PACE-C. So we will open the other centers very quickly. So the current status of the studies. Sorry, this is not allowing me to just click through. PACE-A is open to recruitment. We have 9 centers open. And to date, we have 109 patients randomized. So this is, again, just a reminder, is between surgery and SBRT. It's a difficult randomization, but we are continuing with it, and we're very optimistic we will meet our accrual target. We have another 5 or 6 centers who are now keen to open. And if anyone's online who does want to open, please let us know. PACE-B completed recruitment in January 2018. We recruited 874 patients from a target accrual of 858, so we slightly overshot our accrual target. We recruited 6 months ahead of target, and all the patients at treatment are in follow-up. The 12-week acute toxicity data has been analyzed, and we presented at GU ASCO, which was the clinician-reported outcomes, and at ASTRO, the patient-reported outcomes. And all of the acute toxicity has now been published in the Lancet Oncology. PACE-C, as I just mentioned, is now open to recruitment. The Royal Marsden is open, and we've recruited our first patient. But with the next few weeks, we'll have multiple centers open. And it's going to open in the UK, Ireland, and Australia. Currently not going to open in Canada, which is disappointing because the Canadians were fantastic recruiters to PACE-B. So just to show you the PACE-A accrual, that's our target accrual, the red dotted line. Unfortunately, the study is behind target, but it is steadily creeping upwards, and we will eventually get there. PACE-B, on the other hand, went ahead of target, as you can see, and we recruited 874 patients. So this is the presentation which I presented at GU ASCO, which is the analysis of the clinician-reported acute toxicity outcomes in the trial. So 874 patients with localized disease. It was a 1-to-1 randomization between 36.25 gray and a cohort that initially got 78 gray. Most patients, most centers switched to the 62 gray. The primary endpoint of the study is 5-year biochemical control, and there are multiple secondary endpoints. And the one which was a planned analysis was clinician-reported acute toxicity, which is what we're looking at today. So this was pre-specified sub-study with primary endpoints. So we set the primary endpoint as the worst grade 2 or worse RTOG toxicity within the first 12 weeks post-radiotherapy, and similarly the worst GI grade 2 or worse RTOG toxicity within the first 12 weeks. The power calculation was based on 871 patients and was made prior to final recruitment. And it was set on what we expected for the conventionally fractionated arm based on predominantly on the CHIP study. And we expected a grade 2 rate of GI toxicity in the region of 25%, and have GU toxicity in the region of 40%. You'll see that we actually, all the study was lower than that. And this gave us a power to detect 83% power to detect a 10% increase in GI grade 2 or worse toxicity, and an 85% power to detect an 11% increase in GU grade 2 or worse toxicity. The time points that we measured and what we measured. So at baseline, everyone had RTOG and CT CAE at baseline. Then for patients having the conventionally fractionated radiotherapy, they had toxicity measured at weeks 2, 4, 6, and 8. And for the SBRT at the end of SBRT, and then at weeks 2, 4, 8, and 12 after treatment. For planning recommendations, we really wanted patients, all patients, to have fiducial markers inserted, but we didn't mandate it because we knew that not all centers would be able to do it. Again, we strongly encouraged centers to do a planning MRI scan, but again, it wasn't completely mandated, but most centers did actually complete an MRI scan. For the low-risk cancers, so the Gleason 3+3s, PSAs less than 10, the plan was to just treat the prostate only without the seminal vesicle, and for the intermediate risk patients was the prostate plus the proximal 1 centimeter of seminal vesicle. So of the 874 patients within this analysis, so there's 441 patients who received conventional radiotherapy and 433 who received SBRT. Most people received their planned treatment. There were those in both arms of the study that for one reason or another did not receive their planned radiotherapy. But we ended up with 431 patients with conventionally fractured radiotherapy and 414 patients with SBRT. Importantly to note that most of the patients in this study are intermediate risk. Although we did allow low risk in the study, in the UK and Canada, most low risk patients undergo active surveillance and therefore were not randomized in the study. So 91.4% of the conventionally fractionated patients were intermediate risk and 92.1% of the SBRT patients. Most patients, or the majority, had fiducials, a significant majority within the SBRT fractionation, and 57% of the conventionally fractionated patients had fiducials. For patients who didn't have fiducials, they still had to meet the quality assurance of the study, so they had to send through their cone beam images to demonstrate that they could deliver image-guided radiotherapy without fiducials. For the conventionally fractionated treatment, the majority were treated with a VMAT technique, 74%, 25% were treated with step and shoot IMRT, and 1% had tomotherapy. For the SBRT, again, the majority were 58% were treated with a VMAT technique, and 41% were treated with CyberKnife, and less than 1% step and shoot IMRT. So we feel that patients got high quality IMRT throughout the study, high quality radiotherapy throughout the study. So in terms of the dose, as I mentioned earlier, when we started the study, the conventional dose was 78 gray, and so 29% of the patients in the study received 78 gray. Most centers, not all, but most centers switched over to the 62 gray. You couldn't do both, so you had to elect one fractionation, and most centers switched to 62 gray in 20 fractions. And there was one patient who had a non-protocol treatment because it started with SBRT and then moved to conventional fractionation. In terms of the SBRT delivery, almost everyone got the prescribed, 99% got 36.2 gray in 5 fractions. And there's one patient who again started and then went to conventional. So we come to the toxicity. So the worst RTOG acute grade 2 toxicity for gastrointestinal symptoms was 12% for conventional fractionation versus 10.3% for SBRT. But if you look at the table, you can see that grade 1 is still quite significant. 61% of patients do have some toxicity, whereas only 26% had none in the conventional and 36% in the SBRT had no toxicity. But overall, 12% with grade 2 or worse versus 10.3%. And this was not statistically significantly different. So there was no statistical difference between the toxicity of the two arms. If we look at this in a graphical formation, similar to the chip graph I showed you earlier, slightly surprising that the toxicity is not really coming on that much earlier, but it looks to be very, very, very similar pattern despite the fractionation. And when that's the top line is grade 1, and you can see completely overlapping lines for grade 2 or grade 3. That's for gastrointestinal toxicity. For the grade 2 or worse RTOG genitourinary toxicity, for conventional radiotherapy, it was 27.5% versus SBRT 23.2%. And again, you can see there is some grade 1 toxicity, but still low rates of grade 2 and above. And again, there was no statistical difference between these two arms. Looking at this graphically, this comes on very slightly earlier, peak, very similar for grade 1, and almost completely overlapping lines for grade 2 and grade 3. So in terms of conclusions for the clinician-reported toxicity, you can say that PACE safely completed recruitment and there was no statistical difference between the acute RTOG toxicity. And we found this really reassuring because there was always a risk that the acute toxicity would be worse with the large fraction size. It was shown in Anders Widmark's hypo study that the acute toxicity did look slightly worse, but the radiotherapy techniques in the study were very different. The other thing was that overall, both the control arm and the experimental arm showed significantly lower toxicity than the previous study, which was the CHIP study. So if we look at the CHIP study for the moderately hyperfractionated arm for GI, they showed 38% toxicity, was in PACE it was 12. And again, for the GU, 49% versus 27. So a very significantly lower toxicity in the PACE study from its predecessor, the CHIP study. And we can only really hypothesize that this is due to improved radiotherapy techniques over time. So the second part is shorter, and it's what we presented at ASTRO, and I won't repeat all the initial slides, which are the same, but just go straight to the toxicity. So this is patient-reported outcome. It's not clinician-reported outcome. And my research fellow, Doug Brand, presented this on our behalf at ASTRO at the last ASTRO. So we look straight at the IPS changes from baseline, and you can see that these lines almost completely overlap. So the SBRT is in blue, conventional fractionation in red. It does have a small rise with incomplete emptying at the start and then returns to baseline by 8 weeks. Similarly for urinary frequency, it does rise, but the lines are completely overlapping and the error bars completely overlap and again returns to baseline by 8 weeks. Similar pattern for urinary intermittency, urinary urgency, weak stream, straining. I mean, these lines do not separate in any form. So there's no difference in the patient-reported IPSS scores, which is reassuring because it maps what the clinicians reported. If we look at it in a different form, we look at IPS severity categories over time. This is where it's really important that you record baseline toxicity, because you can see that patients at the start are suffering from some degree of urinary distress. A small number have very significant, severe symptoms. We did try and avoid putting patients with very high IPSS scores in the study, although there wasn't an actual cutoff in the protocol. But if you compare baseline with 12 weeks, the charts look extremely similar. And so this is IPS severity over time. Then if we look at EPIC 26, again, changes from baseline. If you look at urinary incontinence, I think you can barely only see one line because the lines are so closely overlapping. And again, so for urinary incontinence, urinary obstructive symptoms, urinary bother, bowel, sexual, and hormonal bother, the lines completely overlap. The bowel toxicity things do dip, but then get close back to baseline, similar for sexual function, and really no noticeable change in hormonal. So EPIC, minimally clinically important deterioration, which is from a paper by Skalaris et al. We scored this out of 100 and then looked for various different point reductions based on this work. So an 8-point reduction for urinary incontinence, 6 points for obstructive symptoms, and 5 points for bowel. And we asked, so what proportion of patients had clinically significant symptoms? And the majority for urinary incontinence, 79%, did not for conventional, and 84% for SBRT. And those that did, 20% for conventional and 15.9% for SBRT. I did similar for obstructive symptoms for a 6-point reduction. And you can see the 34% for conventional and 34.2%, so extremely similar results. For bowel, again, the results are extremely similar. So I thought this was a useful way of demonstrating that there was very little difference between these two techniques. And again, there was absolutely no statistical difference, not even a hint of a p-value on showing a difference between these. So again, we can conclude that it was the first randomized study comparing 5 fractions of SBRT to standard of care radiotherapy. And again, no statistically significant difference in patient-reported outcomes. And this agrees with what the clinician-reported outcomes show. Follow-up is ongoing, so we will report obviously the primary endpoint of the study. Not too sure yet when that will be, but probably 2 years from now, and late toxicity. Number of acknowledgements, obviously all the patients. Extremely grateful to Accuray, who really made the study happen. Without Accuray's funding, it would never have got off the ground. There's been a huge number of research nurses, urologists, oncologists from 37 centres in the UK, and in Ireland and in Canada. We've had a fantastic trial steering group, an IDMC chaired by Soren Benson. Again, I thank my host organisation, the Royal Marsden, for sponsoring it, and the ICR CTSU who ran the study. There's a vast number of people who recruited. These are just the hospitals that recruited and the number of patients they recruited. And that, for those who are interested, is the paper that is open access in the Lancet Oncology, and it was published a few weeks ago. So if you want all the detail about the study, the stuff I've not presented today, it's all in there. And if anyone is interested in knowing more about PACE, or particularly if you are interested in joining the study, this is the contact details of the clinical trials unit. So the email is pace-icrctsu@icr.ac.uk. Thank you.